Jennifer Frankovich. She is clinical professor in the Department of Pediatrics in the Division of Allergy and Immunology and Rheumatology. She has a clinical expertise in systemic inflammation, autoimmune diseases that co-occur with psychiatric symptoms. She's working at Stanford University at the Lucille Packard Children's Hospital. Jennifer has pre-recorded her presentation so that can start, but she is here to answer questions. So please start the video.
Hello, my name is Jennifer Frankovich. I'm a pediatric rheumatologist at Stanford University, and I study an illness called PANS, Pediatric Acute Onset Neuropsychiatric Syndrome. And many of our patients go on to develop chronic fatigue. So this talk may be relevant to you if you're interested in chronic fatigue syndrome. PANS is a sudden overnight onset psychiatric disorder that involves the basal ganglia. There's been 3 imaging studies now which show basal ganglia involvement. The first was by Dr. Jay Geed at our National Institute of Mental Health, who showed new onset patients have swelling or enlargement of the basal ganglia compared to controls. This was followed by a study by Dr. Chugani, who found activated microglial cells in the basal ganglia region. And we recently published our study, which shows diffusion abnormalities throughout the brain, but primarily in the basal ganglia region. This top MRI, you can see the enhancement of the basal ganglia. This is actually pretty unusual to find this in a standard MRI. This is a patient that got an MRI within a few days of onset. Usually patients don't come to our clinic until many weeks to months later. And at that time, you don't see that acute change, but you can see the diffusion abnormalities when you compare a patient cohort to a control cohort. There are many basic scientists now studying this illness in the United States. This is a group from Yale University, led by Dr. Pittenger, who found autoantibodies to striatal cholinergic interneurons. These are the interneurons within the basal ganglia in patients with PANDAS. So that's the what we think is strep-associated PANS. This is an example of one of our first patients that we saw in our clinic. This was a young man who had overnight onset of severe obsessions and compulsions. 2 weeks prior, his sister had scarlet fever. He had very restricted eating due to contamination fears. By the time he came to see us, he was emaciated and he was refusing food and medications. He hadn't left the house in 2 years, and he came to our clinic after having these contamination fears for 2 years. After treating with penicillin and immune modulation, he had a dramatic improvement. Even within a week, we saw changes. And then within 3 to 4 weeks, he was back out playing with his friends for the first time in 2 years, in the mud, losing his contamination fears, and he gained significant weight. And he's been in a robust remission since then. Not all of our patients have such a good story. We're still learning about this illness. There's nuances. Some patients get better with very minimal treatment, like, for example, NSAIDs, penicillin, and good CBT. And some patients require more. We're still trying to learn the right path for treatments. This is the criteria. Dr. Sue Sweeto from our National Institute of Mental Health has really led the field for PANDAS and PANS. And she published these criteria with Dr. Leckman at Yale and Dr. Rose at Johns Hopkins. And these criteria require new onset or recurrence of very sudden onset of OCD and or eating restriction. and at least 2 other comorbid symptoms. But from our experience, most patients have most of these comorbid symptoms. So basically, these patients are typically normal or functioning at a very good baseline, and then suddenly overnight, they develop a debilitating psychiatric disorder. They're very complex in their presentation, not just with psychiatric symptoms, but with sensory issues, polyuria or enuresis, pain, movement abnormalities, and some go on to develop arthritis and other autoimmune diseases. So it really takes a multidisciplinary team to care for these complex patients. We have a dedicated team of psychiatrists, a therapist, a couple of pediatricians, and immunologists, because some of these kids have underlying immunodeficiencies, and a rheumatologist. And then also we have dedicated consultants. And so this has been very helpful to have a point person on each of these subspecialty teams so that we can improve communication and learning about our patients. For example, we work with our sleep team to understand the sleep issues of these children. Most of these kids have normal sleep, and then when they develop this sudden onset illness, they start having significant sleep abnormalities. The most interesting is this REM motor disinhibition, also called REM behavior disorder, which has now been found in 3 cohorts, the NIH cohort, our cohort, and another cohort in Italy, and that publication should be coming out soon. So basically, these patients are moving during REM sleep when they're supposed to be paralyzed, and we think this is an important clue in the illness. So this is the time-dependent risk for developing chronic fatigue in the first 10 years after onset. So most of these kids have no issues with fatigue prior to the onset of PANS, but then over time they develop chronic fatigue. We're still trying to learn what are the risk factors for developing fatigue, and trying to understand what helps these kids get better. We have a long way to go to understand that. And like other chronic fatigue illnesses, these patients also have pain amplification, which is oftentimes self-limited. And some develop even CRPS. 15% of our cohort met American College of Rheumatology criteria for fibromyalgia. The pain onset is typically close to the PANS onset, but they can develop a pain disorder with a future relapse. Most of the patients in our cohort actually have a relapsing and remitting course. In addition to the pain amplification, we actually see arthritis too. This arthritis is very subtle. It just makes the kids a little bit achy. It's not a significant symptom, but it has given us important clues. Interestingly, capsular thickening is seen on joint ultrasounds, which we think is an interesting finding and hasn't been reported in kids, but may be related to psoriatic arthritis. And as you can see, there is a delay to the diagnosis of arthritis, primarily because of the pain amplification and the difficulty in assessing arthritis when a patient has pain amplification, which is why we are now using imaging modalities to help us make the diagnosis of arthritis if it's present. Oh, whoops, sorry. Oh. This is the time-dependent risk of developing another autoimmune disease, so not including arthritis. So 20% of our cohort did develop some other autoimmune disease, most commonly thyroiditis, psoriasis, celiac disease, Behçet's. We've had one patient with type 1 diabetes, and we have some other unusual and rare autoimmune diseases in our cohort. Most of these autoimmune diseases occur after, or at least are diagnosed after, the onset of PANS in the many years to follow. So we are very curious as to what is happening at PANS onset that is potentially predisposing these kids to developing other autoimmune diseases, Or is it the immunogenetics of the child that sets them up for PANS and also these other autoimmune diseases? This part we don't know. So when we started our clinic about 8 or 9 years ago, we decided that, well, we realized how little we knew about the illness. So we started a longitudinal biobank where we're collecting blood specimens and in some cases CSF specimens on patients when they present to us, but then also when they go into remission and when they relapse. So we have about 200 patients and 100 controls in our biobank with about 1,200 blood draws. And we are collaborating with researchers primarily at Stanford, but other places as well, to characterize the immunology and genetics of this disease. And also our aim is to look at non-human genetics in order to see if we can understand infectious triggers. This is our immune behavioral health clinic. All these clinicians are dedicated to the care of PANS at our institution. And this is the clinic research team, who I'm very grateful for, helping to coordinate all these blood draws and collect clinical data on our patients. And we're also very grateful for our basic science team who are studying these specimens. There are about, 12 centers or so in the United States, well, and also a center at the Karolinska Institute. There's a couple of centers in Italy. So we're hoping to do more organized research among everyone to understand this PANS illness and understand the fatigue that follows. Our funding comes primarily from Stanford, as well as the PANS Physician Network. We've received startup funds from the US National Institute of Mental Health, as well as many other donors, the Codwell Children's and the Dolinger family for their donations to support our biobank. If you would like any more information about PANS or our program, please visit us at med.stanford.edu/PANS. Thank you very much for your time today.
Thank you very much, Jennifer, for this nice presentation. I think a good example on how to really set up a good cohort to study, and also to do it in time, longitudinally, in relation to with building up a biobank. I have some questions, but I would first like to ask Sabine if there are questions from the audience.
Yes, there are. People on the chat are wondering about the relation between ME/CFS and PANS-PANDA, I think. So to sum up, what similarities do you find between the two, and how is your research contributing to the research on ME/CFS? And lastly, what criteria do you use for ME/CFS?
Mm-hmm. So I don't know that there are good criteria for children, but right now we're using the International Institute of Medicine here in the US has a criteria for ME/CSF, and that's the criteria we use. So only 10% of our cohort has so far gone on to chronic fatigue syndrome, but almost all of our kids develop a fatigue illness after the PANS illness starts to resolve. So they may not go on to meet the criteria for ME/CSF, but they have a period of time where they're very fatigued, they wake up unrefreshed, they have a foggy brain, but then eventually it gets better. So far what we've found is the kids that have had chronic PANS are the ones that have a longer duration of the chronic fatigue syndrome. So we suspect that earlier treatment of PANS and more aggressive treatment may help prevent a prolonged fatigue illness. But in many cases, we still don't understand what triggered PANS, and we don't have a good idea of how to treat it. So in the cases where the kids come to us and they have a clear strep trigger and maybe coinciding sinusitis, and we treat the sinusitis and we give anti-inflammatories, their PANS, that getting them over the infection is very easy. But in some cases, I don't think we understand what the infection is. And so getting them better is very difficult. So that would be the same situation with COVID-19, where we can't, we don't know how to treat that illness so well, although now we're learning. So hopefully we'll be able to decrease the number of cases of chronic fatigue.
Thank you, Jennifer. Any other questions from the chat, Sabine?
Yes, Hemo Drexhagen asks, you said that PANS patients have immune deficiencies. Are you talking about several T-cell deficiencies or other deficiencies?
Yeah, so only 4 out of our 200 or so cases met criteria for a pediatric immune deficiency syndrome. In those cases, they had chronic variable immune deficiency. The rest of the kids don't seem to have immune deficiencies, although many of them will at some point develop transient decreases in the immunoglobulins and some other subtle sort of abnormalities. There may be some intrinsic immune deficiency in these kids. We just don't know. And the immune deficiencies may be a little bit different in every kid. For example, we have found a subgroup of kids with very low C4b. So they don't have the C4b gene, and they don't make that complement. And that might be a factor in not being able to fight encapsulated organisms. So right now, in terms of how we're managing these kids, we're looking at them sort of at an individual level as to what is going on with their immune system, what's happening with infections. And then we're trying to study them as a group as well. We are finding some similarities between the patients in terms of immune activation markers, in particular monocytes. We're finding some interesting things there. And then some certain activation markers on B and T cells. But that may actually just reflect the infection that gets them into the PANS illness. And the other thing is that we suspect that what's happening during the chronic fatigue phase of the illness is probably different than what's happening at PANS onset. The PANS onset may actually reflect that infection, and since the kids are young, it manifests more of a behavior disorder. But then what's happening once they become fatigued may actually be a different sort of metabolic immune event. So, so we're trying to study those samples in different ways.
So this really triggered a question basically for all of you who are in this discussion is how important is it when setting up the ME CFS research in the Netherlands is also including special attention for the pediatric patients who suffer from chronic fatigueness? So maybe you can answer this, Jenny, or maybe Mike or Jonas.
Mm-hmm. I mean, I think it's interesting because you get to see the kids right at the beginning of the illness. So we're actually getting samples from patients even before they get chronic fatigue. So understanding like the differences between before and after fatigue. We also found that there's a high rate of having siblings. So enrolling siblings into studies is really important because again, you can get their samples before they develop the illness. And really validating like the beginning of the fatigue illness. I mean, I think in adults, it's always, it may be, I don't know, I don't treat adults. It may be hard to sort of really pinpoint when things happen, maybe not, but in kids, it's very clear when it happens. I mean, it's clear with the school records, it's clear with, the teacher reports. It's just very clear that they were fine, absolutely zero fatigue, zero mental health problems, and then bam, their whole life changes. I also think it's important to study the kids because they're sort of under their parents' watch. it is much easier, I think, to get, well, I don't know, maybe I think it's for our clinic, it seems to be very helpful to have the very clear history around the onset of the illness and what's happening in the entire sort of family in terms of infections and other potential triggers.
Michael, you want to comment on this as well?